And thank you, Robert. You know, I guess it's time to publicly apologize to you. I was invited to a rock concert. You're talking about Rockstar. And this was not too long ago, I'm embarrassed to tell you. And I realized I'd never been to a rock concert. And I don't want to mention who it was because it'd get tweeted or something now. But I will just say it was an Irish singer in a big rock band, really, really big. And it was at some sports type center. I can't remember, hockey, football, something. And I saw this John Kerry, you know, who as all of you know, is the father of one of my students. That's what he's known for. Vanessa, Harvard Medical School graduate Vanessa Kerry. And he said, Paul, you know, I really want you to meet. And he was talking to someone who's, you know, I thought, you know, television actor maybe. And he said, oh, Tom, I really want you to meet Paul Farmer. It's like the rock star of global health equity. I'd heard that before. And he started going on and on, hometown, you know, about partners in health and our work. And I said to the other guy, trying to interrupt because I was embarrassed and turning pink, as my people do. And I said, so, Mr. Brady, what is it you do? Now, I would, since I know he is a protege of yours, I want to tell you that he was extremely he was very polite. And but it was the year that they had won a Super Bowl. So I'm sorry, Robert. Now, I feel the same excitement that Gary mentioned and Derry mentioned today, just looking around the room and thinking about the promise of community-based care for the future. What could be more important than the mission of linking academic medical centers to health and social justice, to the really grave dilemmas that we face in the world today? And, you know, there's a difference between what used to be called international health when I was a student. When I came back from Haiti to medical school, that was over 30 years ago this year. There weren't many people interested in health and social justice in the class. I mean, I had great classmates. I'm still friends with or work with many of them. But if you were to say international health, a couple people were involved. And part of the reason I believe is that this is not about international health. It's about global health equity. Boston's on the globe. North Carolina's on the globe. Haiti's on the globe. It's not three worlds: first world, second world, third world. It's one world we live in. And the power of caring about other people, the power of marshaling the resources of science to bring those to bear on the pressing social problems of our times is enormous. Now, it is also our job, right, as those of us who are nurses or physicians, it's our job to do that. But the power, even to reach into those, what was already called this morning, social determinants of disease, the large-scale forces that overwhelm us as clinicians, but really overwhelm so many of our patients. That's why community health is so important. That's why the notion of community is so important for our professions. Now, I'm going to give some examples and keep this short. Oops. I do have 2 hours, right, Derry? Now, I would like to also say that, like many of you here today, it was Derry Stossel who said, I thought rather charmingly, would you care to go to breakfast tomorrow at 7 a.m.? I said, what am I, a surgeon? Actually, I was between Haiti and tonight Rwanda, But when I got into this room and felt this energy, I'll tell you, there's nothing that could make me feel more awake. Now, I wanted to show this not because I'm going to talk about hospitals. I'm going to talk about community-based care. But this is an image familiar to many of you. This is the Mirebalais University Hospital in Haiti. Gary helped to launch it. I mean, most of you in this room looking around have supported this work in some way. Some, like Matt Fishman, believed in it decades ago. We've been doing this work since all the time I began making that trajectory between Harvard and Haiti, 30 years now. But this hospital is part of that spirit of community health. And notice on the front of the hospital it says University Hospital. And let me tell you, after the earthquake, with the near complete destruction of the academic medical centers, the places where doctors and nurses and pharmacists and health managers can train, after the near complete destruction, the argument was made when Partners in Health, on whose board Gary sits, that we should build an academic medical center, was scoffed at by many experts. Now, it was never scoffed at by any patients, by our Haitian colleagues, by the Ministry of Health, by the city of Mirebalais, which had no hospital. It was scoffed at by people who thought they knew better because of their expertise. And I respect expertise. I'm an infectious disease doctor. I like it when the surgeons obey me about antibiotic use. But this effort was supported by this community here. And another one of the points of mild derision was, well, how can you have a university hospital when there's no university in central Haiti? And our answer was, no university yet. And Gary, I got to say, is one of the people who said, having good health care, that is, hospitals, clinics, basic science research, people who care, communities who are not themselves health professionals but come on board because they feel that's part of what a community needs. You can drive forward the development of an entire region, a city. And that's what we hope to do in the work we do, often with many of you across the world. And now I'd like to talk a little bit about how I think that's related to the graduates' work here today. Now, this was my dilemma as a med student. Right here in these hallowed halls, can't tell you how many times I went between the Mass General and rural Haiti. And in the place where we worked in rural Haiti, and the we includes Ophelia Dahl, and many of the people we still work with today, this is also 30 years ago, there were no hospitals, no clinics, and also no community health workers. And so building a system when you're moving between the Mass General and the Brigham, where I would later train and spend 20 years, and I'm still working there with joy, is a contrast experience. And I wasn't mature enough in my 20s to really manage that contrast. You know, if you're working in a city like Boston and you go to a difficult circumstance, a clinic, a hospital, it could be in an ICU, could be on a home visit as a community health worker. You go there and then you can retreat to your own space. It becomes very difficult when you're living in a village or a squatter settlement or a slum with informal housing. And I became more, and then when you go back across that border to sometimes even ostentation, right? It's a difficult experience emotionally, but it teaches you a lot. So for me to start my medical career, again, very humbly I'm saying this because I wasn't even a med student, it was the year between college and medical school, to start in a squatter settlement where people have lost their land, have no electricity or water, was a very instructive thing. And I think there's two paths that you can take, and this is maybe the only kind of graduate commencement kind of comment I'll make, right? Avuncular praise gets old. But The thing that we all need to resist in our work in community health is not to lowball our aspirations. That is to think about other people's healthcare problems, people who are poor, marginalized by racism, by gender inequality, people who are unemployed or unstably employed, people who don't have housing security, people whose everyday life is on the edge of this terrible insecurity. And that includes also having a legal system fail them. You know, the carceral response to poverty is one of the biggest problems facing our nation and a few others as well. That is, we use jails to take care of people who are sick, with mental illness especially. I mean, is that a way we want to proceed with community health? Of course not. So lowballing our approach is a major, major concern. And I know it's a major concern of many of the graduates here today. On the one hand, the Mass General, and on the other, a clinic poorly designed by us in the middle of a squatter settlement. Now, if the clinic was poorly designed, it had to be rebuilt. It was. It turned into a hospital. Many of you have been there. But we never really got to where we wanted to go. We knew we needed to build a system that reached from a hospital and a clinic into people's lives where they lived. And that's what we did. And there's, whenever we opened the doors of any clinic, this happens to be one in Central Haiti also, this happened every day. And you can imagine, here's another, avuncular bit of advice for those of you who are embarking on these careers. You need to be able to step back and think sometimes. And it doesn't happen when you're a physician or a nurse practitioner or anyone sitting in a crowd like this. That's another reason the Kraft Center is a jewel in the crown of the Mass General, but also a jewel in the crown of academic medicine, elevating the important piece of community health and expanding our notion of what that means in the fight for real health and well-being, including social justice, but also a chance for the fellows and all those who participate in the programs to stop and think. What is it we're trying to do? How can we do it better? What are the systems we need to be put in place? And then, some really important kinds of questions like, can we build compassion into our medical systems? I mean, I think the answer has to be yes. Can we build mercy and solidarity and a real sense of justice into these systems? I don't see why the answer cannot be yes to all of those questions and why it shouldn't be. These are the kind of programs that are going to drive that agenda forward. Now, learning how to step out of this, and I'm not talking about a bunch of people who look like me. I'm talking about my Haitian coworkers, nurses especially, meaning most of the management and leadership comes from nurses in our work, but also a very significant collection of other healthcare professionals, physicians especially, and pharmacists. How can we protect them? And I got to say, this is something that Gary said to me many years ago when he was president of the Brigham, is you need to focus on leadership, helping people become leaders. And you'll do that by protecting time for them to think about these questions that are very difficult to contemplate in the hurly-burly of clinic or hospital or rounds. And I think sometimes in academic medicine, we romanticize the notion of, you're always in the thick of it, whether you're focused primarily on research or clinical services or teaching. You're always in the thick of it, and you don't have time for such touchy-feely kumbaya type things as reflection, exchange with your peers, learning from other people. We need to protect this. Now, here's the model that we've done, and you'll see that it's not too dissimilar from what we need to do in the United States, right? I sometimes joke with my students at the Brigham or at Harvard and say, This is really complicated, so if you need to take notes, I'll slow down. Now, it's a very strange thing in a world riven by these kind of inequalities. You know, you'll have people, us, the experts, meaning this is a warning, I hope, to all of us. We tend to get enthusiastic about one part of this puzzle, the part we work on, right? But that's a mistake. I happen to be a hospital practitioner at the Brigham and at University Hospital in Haiti, but that doesn't mean I'm saying, look, imagine if I had said, along with my colleagues 15 years ago, you know, in order to treat AIDS in Africa, far and away the leading killer of adults and children in Africa, and responsible for the plummeting of any gains made in the 60s and 70s. Imagine if I said, in order to treat AIDS, to respond effectively to AIDS, we need to recruit thousands of infectious disease doctors. That would simply be conflating my professional training with the need. That would be false. What we needed to train, who we needed to train, were community health workers, and to link them into a system that provides humane care for everyone. Same problem, by the way, major mental illness is the ranking cause of suffering in most quantitative studies of affliction in the world today. Yes, we want psychiatrists, right? But psychiatrists alone would never be, even if we train psychiatrists or surgeons or infectious disease nurses, doctors or nurse practitioners, we're not going to catch up unless we have a system like this. That is the system that you all fit into. I mean, one of the fellows, Risa Pereira, is a community health worker. This is a distinguished effort to really reach from clinic and hospital into people's homes. We should all be proud. I'm proud of you, and I haven't even met you. Same for clinics, right? Some of us would believe that most medical care can be provided in clinics. In Africa and Rwanda, most of our clinics are run by nurses, right? And they're the vital piece of this. And some parts of this are hospital. I had this experience. By the way, I have another Robert Kraft story, more of Myra Kraft story. I have been to rural Rwanda with Myra and Robert, just as I've been with Derry and Gary and Winkin and Blinken and Nod. I always wanted to say that publicly. Gary and Derry and Winkin. Anyway, I'm lucky enough to have traveled with them. And Myra, on the way from the airport in the city called Kigali, that's where I'm going tonight, said, and those of you who knew and loved her, first of all, let's say she was a little bitty person. That's scholarly language. And she said, Paul, I just want to tell you, I don't like snakes. There aren't any snakes here, are they? I said, no, there are not any snakes. Which, of course, was completely false. But I thought it was a good, affirming lie. And she brought it up several times in the course of the visit. A visit to a hospital, a district hospital that we'd just rebuilt. It had been abandoned since the genocide and war. And by the way, I also remember that in the women's ward, a patient, we always say there's no health without mental health, right? She did not have it. Anyway, she kept on walking up to Robert and got about, right in his face. And now I would have found that intimidating on my first trip to Rwanda. But he just put his arm around her, and that diffused the whole situation. The snake situation, however, was yet to unfold. So we went on a home visit because, again, this is the model. You have and the community health worker went with us, and we went to a house not too far from the hospital, just across the street, and we walked into a house, and we were kind of showing it off, like this is a house we helped them rebuild. And Robert's looking around saying, oh, these poor people, this terrible house. I said, Robert, that's the after. This is the one we fixed for them. So it's not like the Tom Brady of houses, and it got worse. So Myra, being a mother hen, was saying to me, what's wrong with that little girl's foot? And I said, well, I don't know, Myra, I was with you, and I just got here. And besides, my Kinyarwanda, the local language, is not very good. So I said in French to the community health worker, I said, what's wrong with that little girl's foot? And she said, oh, snake bite. And I'm thinking, I look at Myra, look at Robert, think, will I be given absolution for the second lie in one day? Anyway, I didn't. You'll remember that. She forgave me, worried about the little girl. Now, this model, if you think about the United States or think about Haiti or Rwanda, and I'm not going to go on too long. I have another hour only. This is an important thing. Why do we have to fight for community health workers in the United States? It's absurd. We don't have a model of medical care that can reach into homes when people have chronic illness, often more than one at a time, and not just the elderly and frail, but people who have addiction, mental illness, and another problem. Why should we have to fight for this? This makes all the sense in the world. Plus, we have the leaders of American academic medicine on our side. So again, here's another, I believe, likely outcome of the Kraft Center's efforts, is to push forward a sensible approach to delivering medical care, especially for chronic disease in the United States. This is the way we do it in Rwanda and Haiti, and that's why, just take a disease like AIDS, that's why our outcomes in Rwanda and Haiti are so much better than the United States. I mean, that should shock you. Mortality is lower. Viral load suppression, and again, I won't go into the medical details, are much better in Rwanda, maybe even twice as good in the United States. Also, if you compare something like HPV vaccination to prevent cervical cancer, Rwanda has already doubled the rates of vaccination among teenage girls from what we can tell from the CDC data. So there's a lot to learn from the experience of our coworkers in places like Haiti and Rwanda, and there's a lot to teach. But it won't happen unless we develop this leadership, as Gary said. As Gary said to me many years ago, and is clearly true. Now, in places like Haiti, the biggest objections were not to community health workers. That's been the problem in the United States, but to hospitals. It's not cost effective. It's not possible. They're too complex to run. You don't have the staff. You don't have the ability to do upkeep. And I would say it is our job to prove all of those naysayers wrong. It is our job. And we will. Because we do need hospitals. I hate personal narratives when they're from me. But I will tell you that I had done my medicine rotation here at the Mass General and loved it. 3 months here. And I knew all the Haitians here. I mean, I'm looking around, but they talked to me. In fact, they talked to me. I spoke Creole, which is a bit of a novelty, right? And, I was 3 months every day. I practically lived here. And on the way back to Haiti, and before my next rotation, I got hit by a car on the corner of Fresh Pond Parkway and Huron Avenue. 20-something years old. And, it just goes to show you, listen to your mother when she says, look both ways before you cross the street. But anyway, I'm lying in there in the road, and the ambulances come. And, by the way, the guy who hit me, he came over, and I said, I am so sorry I walked in front of your car. And he looked at my best friend, Todd McCormick, from college, friend of Robert's and Gary's as well, and he said, did he get hit in the head? And he said, nah, he's always like that. But the guys leaned over me. You haven't heard this version of the story. The guys leaned over me and said, the EMT guys, I clearly had a broken leg. You know, after 4 years at Harvard Medical School, I could see if it was at that angle, that was not good. And I hadn't done my orthopedics rotation. Anyway, he said, well, young man, we're going to take you to Sancta Maria Hospital. Now, I thought, I'm a fourth-year medical student, and I've never heard of Sancta Maria Hospital. And I stuck up for myself and said, no, you're not. Take me to Mount Auburn. And so I did, and then I got transferred here and as a patient. And, you know, I had rehab, I had pain control, I had great surgeons. I mean, the surgeon who took care of me, Arthur Boland, was also taking care of your giant hulking athletes. I hadn't quite figured out if it was football or baseball, whatever. They did something like that. And then I went back to Haiti, and I was fine. But that's not the way it is for people facing problems of poverty. And I'm not talking about in far-off Haiti or Rwanda. I'm talking about everywhere. The leading cause of destitution, you know, people who fall through the cracks from poverty into destitution, is catastrophic illness. And preventing that with community health workers, preventing complications, learning how to use clinics, learning how to look out for everybody is what the Kraft Center Fellows are all about. Example from my own work, this is a patient with AIDS and tuberculosis, typical patient, later became a good friend of mine, patient of mine, Joseph is his name. You know, people come in really sick. He needed a hospital. He had AIDS and tuberculosis. He couldn't even talk. He was obtunded, right? And then, you know, after being on therapy, goes home, community health worker is the one providing his care. Comes into a clinic, nurse, this is how you take care of even the sickest when they get better. And when you look at what would have happened if we had not intervened around AIDS, you know, you hear about these programs to take care of AIDS in Africa, and I'm telling you that I'm so proud of them. And as Americans, you should be proud that your tax dollars have supported it. That's why this didn't come to pass. It stopped. It's being reversed. We're bringing together these outcomes because we invested in the staff and stuff we need, and that went from community health workers to clinics to hospitals. That's why this has all been reversed. These are the steepest declines of mortality ever seen because we've never really introduced modern medicine to poor people. And that's the kind of return that we can get when we make sure and keep equity, fairness, justice front and center. Now, since one of you is working on HCV, I'm just going to say that the burden changes right over time. This is Maggie. I made this slide for Maggie. So Maggie is working with healthcare of the homeless and thinking about hepatitis C. Well, she should be. We all should be, because bad news, hepatitis C has now crossed with AIDS as the leading infectious killer of young adults in the United States. Even better news is, finally, instead of what we used to see when I was a student at the Mass General, when people were getting interferon, you know, for their treatment, which we used to call shake and bake, because they would have these horrible reactions, and they didn't always get better. These new regimens will cure everybody who gets them for the adequate amount of time. I say everybody. That's an exaggeration, perhaps, but pretty close, right? If we get the diagnosis right, less invasive lab tests. Now, how are we going to do that without a community-based platform? Does anybody else figure that out? How do you get people to adhere to long-term treatment, even if it's an oral regimen, as these are? You need help. You need being part of a system that goes from communities, from people's homes, all the way to the hospitals, and which they won't need, you know, if they get that kind of care that could be delivered with this system. And just the last thank you. I just want to mentioned, both Mark and Kate, who you'll hear from today. One of the biggest problems is integrating, right? How do we integrate? How do we integrate community health workers to clinics, to hospitals? It's difficult. I mean, if Gary can bring together the Brigham and the General and make them play nice and love each other and sing Kumbaya and hold hands, yeah. Well, or even give the appearance of same. It's a very big, it's difficult to put everybody in a team. It's difficult, but it's worth it, right? And what Mark is trying to do, he's a psychiatrist, is link people together so that we can provide care between a community health worker and, of course, people's homes, and a system. We call this sometimes a medical home. And again, there's no health without mental health, but mental health complicates other illnesses. Any illness, I mentioned AIDS or tuberculosis, I'm an infectious disease doctor, but any serious cardiac ailment, you have higher mortality rates because people are not able, because of all kinds of barriers put in their way, able to adhere. One of the biggest barriers, by the way, is the splintered nature of our healthcare system. So people, compassion, that's what brings, that's what's going to make a difference here. And Kate, as well, is trying to make that link with kids, with children, also psychiatrists. How do we make sure that teenagers and other kids are brought into a system that has a warm embrace and is not asking them to do things that we wouldn't want them to do, meaning come in all the time to a hospital? This notion of community-based care is critical to the future of American medicine. And it doesn't mean that we need fewer specialists or whatever the arguments that then get generated. I'm a specialist. I like it. I like being in a hospital. But I don't want to conflate my own personal training, ambitions, or interests with the needs of a population that is clearly being underserved. And I think that's what all of the people who are graduating here today should be proud of, that they're part of this movement to make American medicine, as broadly conceived, lived up to its promise. This is a Navajo woman, right? The woman whose blood pressure is being taken by a community health worker. I was sitting right there. And let me tell you, when I went to do a home visit with this woman, what really hurt me the most, an elderly woman, first of all, the fractured way places she would have to go to get help. The second, I couldn't speak to her without a translator. She is born and raised for people here for thousands of years. She doesn't speak English. Nor did she have running water in her home. So these are not problems that we see only in Haiti and Rwanda. These are problems we see everywhere. And using our medical talent, developing their leadership skills, and I say medical meaning doctors, nurses, frontline workers, and the managers who help us to make sure that we can do this work, harnessing that talent, supporting it. That's the real genius of what Derry has done with this program, which required, as was said, support. When you start something new, you require support. And for enlightened philanthropy, and more than philanthropy, really accompaniment. The Kraft family they've been stalwarts in the city and across the world, as we know from our work. So to the graduates, congratulations. It's been an honor to be here today. And I look forward to getting to know many of you. Some of you I do know. But I look forward to getting to know you over the years and working together here in this city and elsewhere as we really, once again, make medicine live up to its promises to serve all equitably and with justice. Thank you.